Hello, everyone, and happy Friday. Welcome to EMS Focus, a collaborative webinar series. I'm Gam Wijay Tunga, Director of the Office of EMS here at the National Highway Traffic Safety Administration. Obviously, you're aware of our EMS Focus webinar series since you're here today, but I just want to remind you that we produce one webinar each quarter to bring information about EMS system improvement from NHTSA and the Office of EMS and from other members of the Federal Interagency Committee on EMS, or FAEMS. We address a variety of topics on these webinars and encourage you to register for upcoming webinar topics and sign up for those announcements via email at ems.gov. Before we begin with the main content of our webinar, I'd like to handle a little Zoom housekeeping. You can use the Q&A button in your operation panel to submit questions throughout the webinar, and we'll address those in the Q&A portion of the agenda in the last 15 minutes or so of the hour. Feel free to submit questions as they occur, and our facilitator will collate them at the end of our speaker panel presentations. And you can use the Show Captions button also to view closed captioning at any time during the webinar. Very quickly, before we dive into our topic today, I want to remind you about the focus of NHTSA's Office of EMS. The Office of Emergency Medical Services, which also houses NHTSA's National 911 program, supports the improvement of patient care in the out-of-hospital setting on a national level. We do so in three ways: bringing together available data and industry experts to identify the most critical issues facing the profession, tackling those issues through collaboration with partners, including other federal agencies and national EMS organizations, and by providing awareness and education about best practices and evidence-based guidelines. A little background on the National Roadway Safety Strategy, or NRSS, which utilizes the safe system approach to guide our national activities on roadway safety. You'll notice that post-crash care is a key element of the safe system approach. And the objectives of the safe system approach focus on safer people, safer roads, safer vehicles, safer speeds, and post-crash care. Post-crash care is focused on enhancing the survivability of crashes through expedient access to emergency medical care, while also creating a safe working environment for our responders and preventing secondary crashes through robust traffic incident management. A little bit more housekeeping before we get to our speakers. One of the ways we support the goals of the office is through sharing and storing many, many resources to help EMS leaders and clinicians access information they need. EMS.gov's updated resources hub makes it easy to search for, browse, and download a variety of documents, reports, and guidance created by NHTSA's Office of EMS and our partners and other stakeholders. From the EMS agenda for the future to clinical guidelines and reports, these resources help to advance the profession nationwide. You can access the EMS Resources Hub using the QR code that's up on the screen right now, or just go directly to ems.gov. Also, if you want to access previous webinar recordings and register for updates on future webinars, just scan the QR code that's on your screen right now, and it'll take you right there. This is also on ems.gov as well. So On today's webinar, we'll explore the role of EMS in assessing and treating crash injury patients. As responders, EMS clinicians initiate treatment and ensure continuity of care during transport to the hospital, and we'll also be learning about factors influencing EMS operations, from varied system setups to resource availability and effective strategies for pre-hospital care and outcomes for crash injury patients. All right, I'm slowly mastering the slides, folks. So now I'm very pleased to hand it over to our first speaker, Dr. Matt Levy, Deputy Director of Operational Medicine and Associate Professor of Emergency Medicine at Johns Hopkins University. Matt.
Well, thank you very much, Mr. Director. It's a pleasure to be here with you all today, and I thank you for the opportunity to speak on this important topic. As mentioned, my name is Matt Levy. I am a career-long EMS practitioner and clinician myself, starting off as an EMT, then becoming a paramedic, and now serving as an EMS physician, medical director, and an emergency medicine physician. So we're going to talk about a topic that's very near and dear to my heart. We're going to talk a little bit about pre-hospital blood programs, and we're going to talk about some of the work that I've done locally in our EMS system and the system in Howard County, Maryland, where I'm the EMS medical director and chief medical officer. We'll cover a little bit about these programs, why they're so impactful, and what you should know as an EMS clinician about how the resuscitation of trauma patients with blood is really changing the landscape. Now, if we had to sum up the slide, this portion of my talk, I would say that despite all of our efforts over the past 30, 40, and even 50 years within our advancements in our EMS and trauma systems, trauma still remains one of the largest leading causes of death in any age group. In fact, it's the #1 cause of death for those in the United States aged 1 through 44. And on top of that, nearly 3/4 of all trauma deaths occur either in the pre-hospital phase of care, that's our space in EMS, or during that first hour of hospital arrival. Now, it's important to acknowledge that some of these injuries are simply not survivable. But for those that are, we know that hemorrhage accounts for nearly 40% of all trauma deaths and remains to be a leading cause of preventable trauma-related death, both in the US and worldwide. So there's a lot of opportunity here, and this indeed has been the source of a lot of interest and a lot of focus, both on the civilian side, but also on the military side, where we've been able to translate a lot of very impactful lessons learned from the battlefield to enhance trauma resuscitation. The challenge, very simply put, is that not all patients will survive those 60 minutes through that golden hour long enough to get to trauma facilities where they can receive blood administration and definitive hemorrhage control. We've come a long ways with a variety of interventions, including the Stop the Bleed program, bystander awareness, and many of the other resuscitative techniques that we can use to help temporize and stabilize someone. However, we also know that their opportunity still exists for us to do more for these patients, to change that death slope and that death curve, and to just get them a little bit more time. Pre-hospital blood programs began around 7 or so years ago, and the data continues to emerge to show a very clear and profound impact on survival. Now, when we talk about pre-hospital blood programs, it's important to understand that the topic itself focuses around blood products, and that may be different components of blood. It could be whole blood itself, but more and more there's interest in the use of whole blood, and we'll talk about why that is in a second. In our system in Howard County, we chose low titer O positive whole blood because of the fact that it is the closest by constitution to what patients are losing when they're bleeding out, and it contains all the components of blood products. In our system, we sought to deploy blood to every major trauma victim within 10 to 15 minutes of dispatch. And the way that we did that was through using our existing EMS supervisor vehicles. We have these vehicles strategically placed throughout our county, and our goal was very simply to ensure that we can get blood to people who need it most. We had to build a surrounding training program to train up our EMS clinicians and also ensure policies, procedures, and accountability systems. to make sure that we followed and adhere to all regulatory requirements. And of course, following up on these cases is very important as well. So we can learn from each case, learn what works well, what doesn't work well, and how we can improve. When we think about how it is that we would give the blood, it's important to acknowledge that we have to maintain our blood supply and our blood chain in its current and existing state of quality that the hospitals would use. So in other words, we have to maintain this blood supply with the same degree of rigor and accuracy and responsibility that they do in the hospital. So the blood has to be kept between 2 to 6 degrees Celsius and has to be tracked. We have to know that we're maintaining those times, and we have to have procedures in place to ensure that if indeed those times vary or those temperature ranges vary, that we can immediately course correct for that. It's incredibly important, incredibly essential to the success of these programs. We'll jump ahead here. Hang on a second. I'm waiting for the slides to advance. I apologize, everybody. We sought to develop and implement a blood program that was both clinically effective, but also socially responsible. So we sought to build a zero waste blood rotation system. So the blood itself has a half-life, has a functional life of around 28 days, the way that the blood that we receive comes from. So by day 1, we rotate all of our blood out of the county and we get a new batch of blood. And day 14, we rotate that blood back to our blood bank partners so it can be used in the hospitals with the goal of not wasting a single unit of blood by way of expiration. We feel very strongly, ethically, that that's the right way to do this. We also value and respect the individuality of patients. So we recognize that not all patients would want to receive blood. So we make an earnest effort to consent patients for blood, understanding the limitations that may occur if someone is unconscious. And we also do a brief momentary timeout to see if there's any evidence this person has by way of a medical alert bracelet or a wallet card that might indicate that they don't want to receive blood. As far as the actual tactical administration of the blood, there's no brand endorsement here. This is just the system that we use in Howard County, and it mirrors that of some of our clinical partners. We use a warming circuit to bring that blood up to basically body temperature, and then we use an infusion system to rapidly infuse that blood into the patient to get that entire unit of blood in the patient within a few minutes. And we're very successful at doing that. See, once we decide and we commit to giving that person blood, it's important that we get that blood into the patient right away. And we'll talk about some of those clinical indications in just a moment. We also recognize the bundle of care and the value of giving other adjuvant treatments, including TXA. And if the patient is still hemodynamically unstable after the first unit of blood, giving them calcium as well. Our training program includes an online section that has all the trauma resuscitation, blood resuscitation, and clinical and technical information about using blood, followed by a 3-hour in-person program that we built, including scenarios, case-based situations, and skill stations. Each of our blood administration cases is debriefed in real time or right after the call by myself or one of the other medical directors, and we debrief these as a group, as a team on a monthly basis. In the interest of time, I skipped over our clinical administration protocol, but I want to add that we use physiologic criteria to decide who gets blood. We were looking for an age-defined hypotension. We look for one other hard sign of shock, and this is in patients that we believe are having signs of hemorrhagic shock. So the inclusion criteria is patients over the age of 1 year of age who have clinical suspicion for hemorrhagic shock, age-defined hypotension, plus one other hard criteria of shock, and that could be an age-defined tachycardia. It could be an elevated lactate if there's a lactate level available. Usually there's not. It could be a fast exam if that's available. It could also be end-tidal CO2 of less than 26, or delayed capillary refill, or altered mental status not presumed to be due to intoxication or isolated head injury. Now, this dashboard is actually one patient out of date because we just had a blood case the other day, and we'll talk about that in a second. As you can see, we've given blood from the youngest patient we've given blood to so far is 17, and the oldest is 90. We've given blood to we're up to 4 females now and 10 males. And I want to point to the bottom left-hand corner of your screen because it's very interesting where you see that from an etiology perspective, now 5 of our total administrations were medical and 9 were trauma. So I think it's important that while we are talking about trauma and we're talking about roadway incidents and survival on our roads of travel, it's also important to acknowledge that these programs can also benefit other patients suffering from non-traumatic hemorrhagic shock. The shock index is a metric that we use to measure and compare the acuity and severity of someone's illness when they're in hemorrhagic shock, and that's dividing their heart rate by their blood pressure. And you can see here that before the administration of pre-hospital blood, patients had an average shock index of 1.45. Basically, anytime normal shock index is less than 0.5, anytime you're above 0.7, that really indicates if you're in hemorrhagic shock or bleeding that you could be in shock. So after blood administration, after 1 unit, to get their shock index down by nearly half really, really illustrates the impact that this resuscitation can and this intervention can have. And when we look to our survival, if we take those who went into trauma arrest out or cardiac arrest out of the equation, because there's a whole other layer of confounders there, but we look at those patients who did not go into arrest pre-hospitally, 90% of them were alive at 6 hours and 60% walked out of the hospital or were alive at discharge. Really impactful numbers. So as I begin to wrap up my section of the talk, I wanted to share with you, we've shared our lessons learned on our implementation, both publicly and online. They're available there. We published our lessons learned from implementation in a peer-reviewed journal. They're free for anyone to download and view. And we have a website we frequently ask questions as well, I'd point you to. So thank you so much for listening to me talk about our blood program. I hope that was insightful and enlightening for you. And Gam, I'll turn it back over to you.
Thank you so much, Matt. So now on to our next speaker. I'll hand it over to Otis Oldman, EMS Director at Utah Navajo Health System EMS. Otis.
Hey, Gam, thank you. Thank you for inviting me to be part of this webinar. Hello, everybody. My name is Otis Oldman. I'm the EMS Director for Utah Navajo Health System EMS. We're located in southeastern Utah. We cover the Utah portion of the Navajo Nation. We are considered a frontier EMS service with about 32 EMS providers. So we're a small agency between two stations, the main ones in Montezuma Creek, Utah, and also we have a secondary in Monument Valley, Utah. Just some context with our service, we cover about 1,400 square miles and moves up to about 1,800 square miles with mutual aid that extends into Colorado, Arizona, and sometimes New Mexico. We cover roughly 2,500 miles of roads. Usually that's between 2 to 3 ambulances being available. Our average response time is about 20 to 40 minutes to a motor vehicle accident. And also, our dispatch is located out of Price, Utah, which is 228 miles away. So, it's always some challenges to get locations sometimes of the accidents. We also, because of how far out we are, we implement a lot of quick response vehicles in our agencies. The benefit of that is a lot of times the quick response vehicles will show up 10 to 15 minutes before the ambulance show up. And about 80% of the time, that quick response vehicle shows up before the ambulance, before the fire, and before law enforcement shows up. And all of our quick response vehicles are, equipped up to the ALS level. And because of that, we really focus a lot on emergency vehicle operation courses and, of course, traffic incident management. TIMS training plays an important role within our agency when responding to motor vehicle accidents, and it's a requirement for all of our responders to take that. A lot of times when they first show up, they may be the ones to secure the traffic, or with the TIMS training, we can move the crash vehicles off the road and do patient treatments off the side of the road, which has been a really great tool for us to use. So that's some nice pictures there, some long roads that we cover. A lot of times we get asked, well, why didn't you just request a helicopter? Well, it's a good question. On average, our average response times for a helicopter is 40 to 60 minutes from the nearest city or town. And during the winter, that increases to 69 minutes for a flight service to arrive. The good thing is the flight services do carry blood, and we don't carry blood in our agency yet. But another thing is that we can also make arrangements with a fixed wing intercept, and we can intercept them at the nearest airport to get the patient to some type of specialty care, especially like children's hospital. Because of our distances and response times and patient care times, we do train a lot with the flight crews within our area. They provide a lot of the equipment trainings for us and treatment cares with our program. And some of our flight services nearby have started an auto launch program, which allows them to launch automatically based off information that's given to dispatch from the RP on scene, um, which has been really helpful in most cases, instead of having to wait for ambulance, the EMS crew to dispatch or request for a rotor. Let's see here. And also just some context, our nearest hospital, our critical access hospital is about 40 to 60 miles away. Our nearest level 3 trauma center is 90 miles, level 2, 225 miles, level 1 trauma center is 352 miles. Because of how far out care is, definitive care, we've started to implement a lot of things on our side to help with motor vehicle accidents. We've started looking into and started building our own extrication program and outfitting one of our quick response vehicles, because most of the time they're the ones that show up on scene first. So the EMS crew can start the process of stabilizing the vehicles and extrication process. If the fire department does show up, they can collaborate with them. We've also run into times where we have to call out a different fire department from another township, and it takes them up to another 30 minutes for them to show up to help with extrication. And also with the fixed wing services, a lot of times the primary children's, we do fly patients out from here directly to the primary children's hospital via fixed wing. Okay. One of the things that we've been working on the past several years is that we've noticed every time we call flight service, we call flight service due to that they can get to the hospital a lot quicker than we can and to a little bit higher level care. But we noticed in the past that sometimes it takes them up to 30 minutes packaging the patients, stabilizing the patients. And it seems to be pretty common in the frontier rural areas. And because of that, we started looking at some of our tools, equipments, and training. One of the reasons why we started training with flight crews a lot more for our services to try to create a less scene time. And we've also started looking at some of our equipment. So we started utilizing some of the same equipments as the flight services do. We use the same infusion pumps, the same tubings, the same cardiac monitors, the same airway equipment, and understanding what type of infusions they do and what their pressure rates are, so we can mimic what they're doing. Some of the local flight crews also provide red card trainings for our EMS crews, meaning that the helicopter is able to pick up our crew if needed and transport them to the scene and help package a patient if needed, if the ambulance is not able to get that to that area. A lot of times, it's a lot of the simplest things that we do that really decreases the on-scene times for the flight crew. And it could just be as simple as utilizing the ECG electrode that is easier to transition between two different cardiac monitors. Doing your 12 lead right when the flight crew lands, so they have a copy for themselves and they don't have to do it for themselves. So because of that, we've started to notice that on-scene times for our flight crews have started to drop down to around the 10-minute mark. And if we get enough information to them before they even land, we've done a few 5-minute hot loads on critical trauma patients in motor vehicle accidents. So next slide. And that's really what it comes down to is, let me go back to the last slide there, is how we try to, and because of how much we train with the flight crews, it's also increased our EMS providers critical care knowledge that if the flight crew is not available, we do have all the tools necessary to transport a critical patient to the nearest hospital. And collaborating with the hospitals also makes a big difference also, because we have access to critical access hospitals, And sometimes they don't have surgeons available. So we may have to start calling around to see who's available to take a trauma patient if they need surgery. And one of the biggest tool that we have is TXA. We don't the flight crew that does bring blood, but at times, we do start the process of administering TXA infusions and also starting the secondary dosages also based off the patient's vitals. So, if we're always trying to improve as much as we can for our little agency but we have a large area we cover. And a lot of that we wouldn't be able to do if it wasn't for our EMS staff and crew members and their commitment to the community and how much time they take, because we're still considered a volunteer department, and how much time they take out of their own lives to further their education and knowledge within EMS. So I think I'm right about the 10-minute mark, Gam.
Thank you so much, Otis. So next up, our final speaker, I'll hand it over to Assistant Chief Robbie MacCue at Town of Colonie EMS. Robbie.
All right, thank you, Gam. And folks, I really appreciate you for inviting me here to talk a little bit today about an opportunity that I think everyone here watching has in these next few years to advance clinical care. Specifically, I'm going to be talking about post-crash care and improving safety through a federal grant, infrastructure grant. And to give you a little more context of where we're joining in from, we're going from Otis's super rural area to a less rural, but certainly not metropolitan area of upstate New York here in Albany, New York. So we are between two major cities, and I'm going to get into a little bit about the geography here, but just for a little more context of where I'm joining in from and what we're going to talk about today. But first, a few disclosures here that I'm certainly not representing any federal entities, and I appreciate the invitation by the Office of EMS. Any products or brands discussed here are purely for demonstration purposes. We haven't selected any vendors and it's contingent upon state and local procurement rules for this grant that we're going to discuss. And our Safe Streets for All grant was approved late December of 2023, and we still have to execute on that federal grant, but we're pretty excited to talk about the opportunities here for that we're looking at. And a major concern of roadway deaths is this increase from 2019 to 2020. And in the last 10 years, really the amount of roadway fatalities that we've seen, almost 354,000 people on the roads experiencing dying from a roadway transportation related incident. In 2021, that number was almost 43,000 people killed in a motor vehicle crash. And a good portion of those, almost 7,400 were pedestrians, so more vulnerable populations on the roads. As Gam mentioned earlier, the National Roadway Safety Strategy framework has been critical in shaping our grant to really adapt it to the opportunities we have here. The Safe Streets for All grant is a federal grant that was focused on this idea of Vision Zero, which originated actually from Sweden in the 90s. The idea that eventually we will get to zero roadway fatalities, and it's going to take a systems approach. So we've been talking about post-crash care here, and certainly this is led me down quite a rabbit hole of traffic incident safety, learning more about TIM training, as well as the other opportunities to have safer roads and safer speeds, and conversations with our partners at New York State Department of Transportation, the statewide Traffic Incident Management Committee, as well as our local law enforcement partners that are tasked with enforcement. An excellent infographic from NHTSA here and really unfortunate infographic that highlights the amount of people that had died in traffic-related crashes in 1 year. And the staggering part is nearly 40% of those people that did die were seen alive by first responders and later died. And NHTSA points to the opportunities for interventions, including what we're going to talk about today with data interoperability and coordinating post-crash care with our 911 call takers and partners, and improving our opportunity for safer highways. So the Safe Streets for All grant is a federal infrastructure grant, $5 billion over 5 years. This is the third fiscal year. So our grant was actually in the prior fiscal year. This is an opportunity for EMS to be seen as infrastructure. So we are a pretty critical infrastructure in every local community, but often not funded federally, especially by so at the local level. So it's an exciting opportunity that we were given and that we have here and that all of you really have access to. There is a upcoming deadline here, which I will mention in a future slide. A little more context, we did a collaborative grant approach. The town of Colonie here is a municipal third service, a department of local government, as well as our neighbors to the south of us, municipal system, and the neighbors to our north of us, who are a private nonprofit serving 2 different towns. So we have a significant geographic area for us that really highlights about 30 miles of high-speed roadways. So part one of our grant approach, it's a two-pronged approach here, is how do we reduce the possibility, how do we make our roadways safer while our emergency responders are operating on those roadways? How do we improve awareness that there's a crash on the road? And that's where we talked about piloting and researching transponder technology, for example, HOSAlert and their safety cloud technology that can actually take over an infotainment system in somebody's dashboard and give them advanced warning, maybe 20, 30 seconds warning, saying, warning, emergency scene ahead, use caution, or emergency vehicle approaching, slow down and pull over. These are standards and technologies that are out there that would allow our first responders to be operating in roadway conditions and on crashes, as well as reduce the opportunity for a secondary crash if more people are aware, rather than the traditional 3 to 5 seconds most vehicles get of an emergency vehicle or an emergency scene approaching. We're also going to experiment with other AVL technology. We have a demo of this HOSAlert system, and with just 2 vehicles and about in a few months, about 5.5 months, notifying over 2,800 drivers on the road. So we're excited when we start to scale this to approximately 80 vehicles across the systems. And the other opportunity here is to investigate other technology that will allow us to take information that may be traditionally siloed and on people's personal devices, medical alert, advanced care registries, and how do we ensure that those smartphones, that data is passed through our 911 partners and actually makes it to the providers that are responding to the incident. And maybe in the future, we can identify who the patients are in that vehicle before we even arrive on the scene. And in part 2, I'm going to talk a little bit more about the opportunities for getting more of the health context of what those patients may have from other systems. The other opportunity is also in the AVL space in a box like Samsara or Geotab, and these connected devices that would allow us to monitor vehicles in real time and give us more advanced warning of the potential fleet issues and other information, as well as sensors that can be attached to these vehicles. So I think there's a lot of opportunity here to experiment with technology and make our vehicles a little bit more connected, as well as other smart tires that are on the market that are actually embedding sensors into tires to let vehicles know of hydroplaning. So lots of opportunities here to investigate. The second half that I'll talk about here of our approach, I'm pretty excited about both of these, but this is the idea of a pre-hospital health and safety information exchange, utilizing existing frameworks such as TEFCA and our New York State Health Information Exchange to allow providers at the point of care utilize technology that they're already using. For example, here, our region adopted Samsara for communicating patient information securely to the hospitals. Imagine if this platform has a 2-way API or interface that allows you to identify that patient, ping the appropriate health information exchanges for treatment-related inquiries and get back not 1,000 pages of medical records, but what are the top 3 things that we should know about this patient's care? Allergies, significant history, hemophilia, other blood types, but information that may be pertinent if there's advanced directives out there. Maybe there's specialty care registries. Our region adopted a handle with care registry in accordance with NAMI in New York State, so that parents can get their children into this database. But imagine all these different data sets that may be traditionally siloed and unstructured, being able to tap into those in a secure way, as well as feeding that information back, including outcomes data from the hospital back to the providers to make sure they can improve their level of care. Was their assessment in alignment with what actually happened, and how did that patient make out? And of course, this statistic of only less than 2% of hospital outcome information and patient information of the 50 million records a year that are submitted to NEMSIS actually have outcome information. So how do we make sure we're working with our partners at NEMSIS and our state partners and making sure that all this information is making its way back to the frontline providers in, again, a secure way? The notice of funding for the 3rd year of this grant is open, so I'd encourage you to work with your other partners in your region. Check with your metropolitan planning organizations or other entities that may be interested and that have experience applying for these grants. I will tell you, this grant was significantly easier. We were awarded $3 million in phase 1. Phase 2 funding is for 10 times the amount of funding to scale a project. So there are some great opportunities out there, and you don't have to reinvent the wheel. We have certainly, there's many people that are on this program that actually have significant history and experience with health information exchanges, so we don't have to learn it all ourselves. And I'm about a minute over, but I do want to just say this definitely sent me down a safety rabbit hole, as this opportunity opened up several other doors to partner up with our traffic incident management, our traffic safety division, and actually look at the engineering behind crosswalks and roadways. And there are a lot of technologies out there that can be experimented with to actually protect the most vulnerable populations that are operating out, that are on the roads. And I've just got a couple slides here of different technology that is approved and on the market, but maybe slightly underutilized. And certainly lighting at night. Most of these roadway fatalities happen from dusk till dawn. I think about 85% of them. So there are a lot of opportunities here to study what's working in other areas of the country and see how we can apply it locally as well. I think that's all I've got. And I'll turn it back over to you again. Thanks.
Thank you, Robbie. And thank you to all our presenters for their presentations. Really appreciate everything. It's been very interesting, and I know we have questions that are flowing in through the Q&A. So just a reminder to everyone who's tuned in today, you continue to submit questions using the Q&A chat function in the Zoom panel. We're going to try and get to as many of the questions we can in the time remaining, but we'll also collate the questions and make a written document with answers that will be part of the archive recording of today's session. So on that note, again, just a reminder to folks, just feel free to drop your questions into the Q&A and I'll help moderate them here. So the first question we have, I think we'll go to Otis, and the question was good points on TXA in the super rural environment. What have the results and trends showed with your use of TXA?
Yeah, so that's one thing we've been trying to work on, is trying to get more data on some of the patients that we have given TXA to. A lot of the issues we have on our side is that most of our trauma patients get flown out out of state from where we are, because we live in the Four Corners area. Most of our trauma patients will get flown to New Mexico or to Colorado as the nearest trauma center is level 2. So it's sometimes a little bit more difficult to get that patient information outcome from other states. But if the patient is flown in within Utah, we can get data a lot quicker and pretty easily. But since we're such a rural area and a frontier setting, everybody knows each other. A lot of times we get family members coming over say, oh yeah, so and so made it, so and so is in, physical therapy now, whatever, we do get outcomes just that way. But as far as getting data goes, sometimes it can be a challenge to get that.
Thanks, Otis. The next question I'll hand over to Dr. Levy. Wonderful presentation. We're getting a lot of those comments from everyone. Regarding pediatric patients, hypotension is a late sign of decompensation. Is there any concern that awaiting... Sorry, it just jumped on me. Is there any concern that awaiting true age-related hypotension may be waiting too late? Have you considered using the lowest 10% of normal blood pressure for age to catch patients prior to decompensation?
It's really a thank you. It's really a great question. So thank you to our colleague for asking that. As pointed out, pediatric patients compensate until they don't, and we know this very well. I think, are going to have more contextual ability as we have a growing amount of knowledge about pediatric resuscitation with blood products to answer that question. One of the things I didn't really get into, Gam, is the fact that this is a resuscitative intervention, right? So anything we do is not without risk. In the situation where someone is in profound hemorrhagic shock, the benefit of giving on-cross-matched blood outweighs the risk, right? So we always want to give the right product, cross-match blood if we can, but if someone's bleeding out in front of you, you don't have that time. So we weigh out those risks and benefits in everything we do in medicine. And to answer the question concretely, I would say is as we have a better data set and we understand more about shock, early shock in the pediatric population, which we know more about now than ever, I think we can be more thoughtful about looking at some of those modifiers. So that's my way of saying, yeah, we're looking at that. I think that we need to look at larger data sets to answer those questions, not one system, single system answers, but rather across trauma registries and other things. And take it one step further, how do we predict who's going to need that blood, 1, 2, 3 hours later in their course of care for that reason? So really, really great question. I think it was Joe. Thank you for asking it. More to follow on that, but you are right. We do look at a variety of physiologic criteria as well. And our crews do have the ability to pick up the radio and say, hey, I have a kid who their pressure is okay, but they have other hard signs of shock. Have that discussion with the base doctor and should they get a blood. So that is more of a case by case situation where the answer might be yes, let's go ahead and do that, as opposed to doing it autonomously. So that's my best answer to that. Great question.
Thanks, Matt. So our next question, it was mentioned there was collaborative work going on with 911 dispatch. Can you share some project ideas on that? And I think this might be intended for Otis or Robbie, but I'll throw it open, I think, to the whole group.
Yeah, again, I can discuss some of the opportunities. There are platforms that 911 systems are using. Every 911 call system and 911 PSAP maybe operate obviously a little bit differently, but there are certainly platforms out there that many might be using, such as Rapid SOS, that are trying to create more intelligent 911 answering systems as opposed to more legacy technology systems. And again, if you have your medical information on a smartphone, making sure that information can pass through along the way and embrace video and location. So all that data, how do we pass it through to the frontline providers? And again, in a way that doesn't overwhelm them. So it's a matter of just partnering, asking a lot of questions, getting curious, I'd say, and seeing what support the 911 PSAPs are looking for, and really looking for other successes throughout the country. There are a lot of people that are much smarter than I am that go into the health information exchange realm and make sure that this information can get passed along securely. So feel free, anyone, to reach out if you have a question about any of the grants that I discussed in that opportunity, or if you need a referral to some of the folks that, again, they live and breathe the health information exchange world, and especially in our kind of niche environment operating at the intersection of public safety and public health here in our 911 systems.
Great, thank you, Robbie. And also, you know, I spent several minutes at the beginning of the webinar plugging EMS.gov, but another great resource for folks is 911.gov. We just have a world of resources on there that can, I think, that will address you know, issues of how we interface with 911 is that first point of contact with the patient. Now, let me go to the next question. This is for Dr. Levy. A concern often voiced against EMS use of ultrasound is prolonged scene time. Do you have any data refuting this concern? So any thoughts on pre-hospital ultrasound? Matt?
Yeah, that's a great question. Thank you, Sam, for asking it. I was actually feverishly trying to type a response, so this makes my world a little easier. I'm an advocate for point of care ultrasound in the right clinical context in the right situation. And to answer that question, we have to remember that the whole purpose of point of care ultrasound is to ask a specific question to yield a specific answer that's going to affect patient care. So where we get into trouble with point of care ultrasound is when we do things for the sake of doing them that doesn't really affect the decision at that moment in the phase of care. So with that being said, there are point of care ultrasound interventions and techniques that we do in the emergency department that I don't think always make sense to do in the field. For example, the FAST exam or the rush exam can be very, very helpful in differentiating hypotension. But if they're hypotense, it's more important that we begin resuscitating them for their presenting complaint. Said another way, it's got to be at the right time in the care. Now, the other big thing to talk about for ultrasound is the investment, not just in money and equipment and gear and all that stuff, but in knowledge to get people to be proficient with ultrasound. And to not only in that initial investment, initial learning curve, but also the skills sustainment to be proficient with doing scans. It takes a lot of work. As a guy who trained before we had really a lot of ultrasound and had to learn ultrasound along the way, I can tell you it takes a lot of work, and metaphorically, guys, it's not like going from direct laryngoscopy to video laryngoscopy where you know what you're looking at right away. You've got to really think about the anatomy in 3D. So that being said, it's a tough counter argument to make, but if we're looking at very specific questions, do I see lung sliding? Yes or no? Do I see pulsatile waveform indicating a pulse during cardiac arrest? Yes or no? That's where I think we go with ultrasound personally, pre-hospitally, and that's how I'd answer it. But I would just, Sam, and to those who are looking at planning ultrasound programs, I just work very closely with your medical directors and think through what is the problem we're trying to solve, and how does this tool help us with that? Thank you.
Thanks, Matt.
Hey,
And
Gam.
Otis.
I just had to add on to Dr. Levy. We've been dabbling with ultrasound lately also in the frontier setting. And I think this tool makes total sense for frontier settings when we have so much patient care time. And like I said, waiting for a helicopter up to an hour, you know, but we don't initially do the ultrasound on, you know, it's not the first thing we do. It gets done maybe 15, 20 minutes down the road after we've done all of our interventions and started to stabilize the patient. And we, you know, just a quick EFAST exam. And sometimes we go off the mechanism of injury. Well, is, you know, left upper quadrant was involved. Let's start there first. And if we see free fluid, your exam stops. You don't need to go anywhere else because there's already presence of free fluid in that left upper quadrant. There's no need to check the right upper quadrant. There's no need to right upper quadrant. We may check the lungs, but you know, if the oxygenation is good, then we won't do lung sliding. But once we start seeing the compensation, the saturations, then yeah, we may look at the lungs for lung sliding also. And we think it's a great tool to have in the frontier service just because we have the time available to do it.
I think Otis brings up a great point, which is that it's gotta be sequenced in with your overall resuscitation bundle of care, and it's got to help drive clinical decisions, right? So if it's positive, that helps you a lot, but if it's negative, it might not help you if indeed, unless you have 100% confidence. And one of the challenges with ultrasound is the variability between users, right? So proficiency between users varies tremendously. Great thoughts, great question.
Great. And the good questions keep coming. The next question, what steps are being taken to mitigate skill decay with low volume and critical decision-making, application of transfusion algorithm, and focus interpretation? I can repeat that one if you want, Matt. I think you might want to tackle it first.
Did you want us? Yeah, there's about 5 questions built into there. It's really,
yeah, it's a lot. Maybe,
no, it's a neat question. So skill decay. Let's start with there, right? So
Yep.
this concept of halo skills, high acuity, low occurrence skills, are real, right? Those are the things. Crike, needle decompression, variety of other very, very once or twice in a career kind of skills that some people may do. Some people could even argue that, intubation should be a halo skill, emergency childbirth, all these things that we consider bread and butter for us in EMS, but maintaining proficiency is really important. Now, what's interesting, when we talk to our law enforcement colleagues, I don't know if we have any law enforcement personnel on the call today, but ingrained in the law enforcement culture is this concept of qualification, right? Someone's going to carry a weapon system, they're going to carry a firearm. They know that they're going to qualify probably 2, maybe even 3 or 4 times a year. How many EMS systems out there have their medics qualifying an intubation 4 times a year? Right? It's not the way we're built. We don't think about things that way. But skill decay is real. And this concept, so you take this concept of high acuity, low occurrence skills, and then you take this concept of skill decay, and then we think about this new thing that we call higher frequency, lower intensity training. And we put all those things together. What we realize is we got to be practicing more frequently, maybe not as long in duration. So is the answer going to one Con Ed class for 8 hours every 2 years? Does that really make you squared away to do your job? Maybe, maybe not. But I would rather know that the person taking care of me or my family member has demonstrated skills on an ongoing basis with some degree of regular interval. And I think that's how we combat skill decay. Training, simulation, multimodal education, what we're doing right now, learning from each other is really important. The other questions there, I think, just to get to them really quickly, application of the transfusion algorithm. We spend a lot of time thinking and practicing on this. Now, we require, not every paramedic in my county is allowed to give blood. That's relegated to our EMS supervisor cadre. It's about 30 or so people, and they have to requalify in that skill annually. And so we, same thing for RSI and a couple of these other skills. And that's how we try to maintain that, so that we are not only talking about the technical skill. The technical skill is not the hard part here. It's the brain parts, thinking about what is the right thing to do for that patient and when. Focus interpretation, that's a whole other webinar. But I think there's a lot to be said for, you have to learn the normal before you can learn the abnormal, and you really have to get good at it, and you really have to get it. You have to invest the time. And there are technologies that help with that. The interesting thing, and I'll end on this note, is that AI is going to help a lot with this, because as more and more technologies come out to help us with the AI built into these ultrasound apps and devices, can really help guide you to get the right image and to help answer some of these questions. Thanks, Cam.
Thank you, Matt. That was a battery of questions answered very efficiently. Appreciate it. Hey, we're nearing the top of the hour, and we're going to be running out of time. But as promised, once the webinar is archived, we'll be posting written answers to any questions we didn't get to today. So I do want to thank everyone for joining. We had very high attendance, and of course want to thank our speakers, Matt, Robbie and Otis. It was great presentations. I really learned a lot today, and appreciate you joining us. So thank you, everyone, and please have a wonderful and safe weekend. Bye.